So this is the title, and again, it's a great privilege to be getting to work here at SNI. And I want to just point out, if you haven't picked it up yet, SNF has its first kind of a printed media outlet in terms of its activities. I think it's a beautiful a way to represent the both academic as well as the educational investigative. SNF has its first kind of many activities. Printed and specifically media little bone outlet. There are many publications that revolve around this. And Joe and I'm not going to quote your studies, but you've done some beautiful work around this little bone. In terms of conflicts of interest, they're only of academic nature, and I've published in this domain, so I may be biased towards some of the publications I was involved. I'm not going to quote your studies. So what's the fuss about? Do we even need this odontoid? If you look at the big picture of our skeleton, this is truly a little detail, a little accessory piece of detail that you can really argue about whether or not it actually fulfills a major function. And lest we remember, there's actually a procedure to remove this bone in patients with rheumatoid arthritis to try to take pressure off the spinal cord, and seems to not cause any problems. So the goals of this lecture are to more or less review something around this bone, and that actually starts in a bigger perspective with the population dynamics, which are very important, and a number of physiologic factors that accompany this thing called aging process, and look at a couple more recent treatment insights. And this all revolves around our patients ultimately, who come in. This is a patient of mine, and she's given permission to show her picture, and the lurking evil that this little bone can have towards and against the well-being of our patients entrusted to our care. So I want all of you to now feel empowered to be either neurosurgeons or orthopedic surgeons. It's your choice, and you don't have to reveal that. But I would like to have every one of you show your hands in terms of what you would do with this 82-year-old patient who is your closest relative, your dad, your mom. In this case, it's a male, who had a ground level fall in a retirement home. And the question is, what would you want to have done with this patient, this closest beloved relative of yours? And this 82-year-old is in physically and mentally reasonably good shape, aside from being in a retirement home. So by a show of hands, would you want to have this patient be in a collar? Raise your hands if you want that to be the treatment. It's a little bit displaced. Nobody? No takers? Cameron? No? Canadian minimalist treatment?
It's very displaced. Yeah, it depends a little bit how active she is.
Jordan, you've seen what I just timed this perfectly until you had your mouth at maximum filling capacity. And that filling is right in front of your odontoid, by the way. So if this is your father, what would you want to have done?
That was pretty,
Yeah, that's always a nice evasive answer, but just by a what's your preference? Leave it be or some surgery?
that was operative.
That's surgery? Okay. So by a show of hands, surgery, you're all surgeons now, neurosurgeons or orthopedic surgeons. Just a tepid few, okay? Okay, of course. Sorry, Rod, XLIF is not possible for the odontoid, last I checked. And who would want a halo? Anybody a halo? No? Some would do nothing. Joe, you've published on this, and I know you're not either an orthopedic nor a neurosurgeon. What would you want to do? You've published on this quite a bit.
I don't know the procedure, but I don't want to do the surgery with my mom or dad.
But you do surgery? Too old? That's an important point. Too old for surgery. Okay. So we have kind of, if I may summarize the response of the audience, a little bit of tepid early morning response. But about a third of the audience was favoring surgery. A third was kind of maybe wanting something non-operatively done, age being a concern. And a third either didn't care about their relative or was just indecisive. Right, or just walking into this bee's nest. This is your relative. This is your dad or mom, God forbid, no. But just hypothetically speaking, reasonably healthy, but retirement home. Yeah. And the deadliest of all injury mechanisms, a ground level fall. What's your choice? Surgery, any type, or non-surgical management? Tend towards surgery. Okay. All right, fair enough. Let's look at what we have. So this is what we're talking about. If you all raise your thumb, this is at maximum. I don't see anybody here who has that, maybe Rod. but this is as big as it gets, and I'm not going to make any pinky jokes here, but Dave is not here. Scratch that, Lee, okay? But this is as little as it is. Honestly, this is the range of osseous dimensions that it has. Is that right, Joe? The little ones are like this?
The size of the process. You enjoy the
Pinky, yeah? Now, I've seen this also, so this is what we're talking about. And it's obviously the pivot point of our entire craniocervical junction. So if you look at the main ligamentous structures, and again, Professor Tubbs has differentiated this ways more, and there are ligaments still for sale, ladies and gentlemen. Right, Cameron? For just a minor investment of a couple of $10,000, you'll be willing to name that new ligament you've identified with somebody's name. But this is the main pivot structure of all of the ligamentous structures that attach our head to our upper cervical spine. So it's really actually a fascinatingly integrated component of our craniocervical motion center, which, as all of you know, encompasses half of the motion of the cervical spine. So these are the consequences of an odontoid fracture: pain, deformity, there are neurologic consequences possible, and this is again a sad fact, even death. So that's the real downside, and this is a diagram of the famous Wolfgang Rauschning, a German who practiced at the University of Uppsala and is maybe the most well-known counterpart to Professor Tubbs in terms of his neuroanatomy studies. So Bob Hart is not here yet, but I would love to pick on him right now. But he kind of shook the world of spine care when he wrote the first real nihilist paper, and he's been accused of that also. But it's a fascinating paper, and that's in 2000, where he identified 5 patients who somehow did not have any treatment for their odontoid fractures. This is from his article. And he saw them over 4 years afterwards, and they seemed to be doing okay. Only one patient had real trauma, and I'll address that weird statement a little bit later, and only 2 of those had neck pain, and none of them had neurologic decline. This paper was criticized because in further detail, and this is why I pick on him right now, to elucidate that further, these patients were actually seriously kind of demented nursing home dwellers, so it seems. But on the good side, it seemed to be possible to live and exist with a somewhat unstable odontoid nonunion without apparent deficit. So up to that point in time, there was a clear mantra of identify an odontoid fracture and fix it, or treat it aggressively. Now, a little bit of bigger picture purview. So this is an obvious map of the world, and there are various shades of orange and yellow and red in here. And basically, this is what we're seeing. We're seeing that the more red the world gets, Joe, bad news, Japan is dark red. It's Bordeaux. I'd label that Bordeaux red, okay? The world is getting older and older. Whoever has been at the Global Burden of Disease lecture by Professor Murray from the UW last year during the Wagner lectureship knows that we're around the globe leading longer and unhappier lives. Right, Rosemary? When the older we get, the more neurodegenerative diseases we get, and the more frail we get in our joints and bone structures. And so this is a true challenge. And the other challenge is that age is no longer a corollary for infirmity necessarily. Because all of us know that we have patients, and my clinic is full of these, and Rod's is, right, Rod? Mm-hmm. Who look like this. But then we have, and this is an often used and downloaded image to represent highly vigorous elderly patients. And again, age alone doesn't really matter anymore as a surrogate for infirmity. There are people, my father-in-law, who Rod helped operate on, who's 88, and 3 weeks afterwards he went to Kenya to build an expansion of his medical center there after a major spine surgery. So these are the differences. And this is a dynamic that all of us have kind of come to learn to appreciate, the silver tsunami. And again, the numbers speak for themselves, but we'll have 72 million Americans in this country here who are older, meaning Medicare age plus. This is an unreadable slide, but this is from the famous Lancet publication from Chris Murray from 2011. And the major point I wanted to make is all those of us who are in the spine care business have our future well taken care of. Low back pain is the number 7 problem around the world, and neck problems is number 21. So, and this is rising over time. This is 1990 and this is 2010. So just in terms of the dynamics of prevalence around the globe, These are major problems. And falls are rising also. And associated with that now is a clear osteoporotic problem. So if you look at volumes around the US of major issues like breast cancer, stroke, and heart attack, osteoporotic fractures dwarf all of those. And again, the problem is that with age, we also lose postural alignment. So all of us undergo a sarcopenia phenomenon, meaning a loss of physiologic muscle tone, which goes hand in hand with a settling of the skull, which, as you'll see in a second, has significant ramifications on our health. So the quintessential problem of postural loss, neurodegeneration, loss of activity, is that we're going to have a major population shift in terms of what happens in terms of these fractures. And we can see with this little animation that the actual number of spine fractures is going to continue to rise disproportionately. And so this is something that is a real public health problem, and for which we don't have a real answer yet. And all of us who know that a certain drug, teriparatide, also known as Forteo, is an actual cure for osteoporosis and how difficult it is to prescribe this, know how frustrating it is that the one drug that can actually really make a difference is so very hard to get because it's so very expensive. So this is the problem of these elderly patients with their kyphotic posture and their hyperlordotic neck. And again, we as physicians and practitioners have to somehow figure out how to ride this wave, this silver tsunami, otherwise we'll be crushed by it and not do our jobs right. This was an old slide from Harborview in 2000 where we suddenly saw a paradigm shift. I had loved, as a young fellow in 1990, odontoid fractures. That was one of the cool fractures that happened in young people, like, again, Cameron and our anatomy fellows here. They're young, strapping people who are doing vigorous activities and then sometimes break their odontoid. It had totally shifted just in my short time in medicine. And again, the old injury mechanisms like this had gone and given way to 103-year-old patients who had the most deadly of all injury mechanisms, which is not a motorcycle crash. It is a ground level fall. The GLF, the infamous GLF, is way more deadly, and the reason for that is very simple. It is the people who are affected by this. So loss of balance, loss of proprioception, loss of muscle tone, poor eyesight, poor posture, all these things feed together towards having a really bad outcome from a simple fall, and all of my neurosurgical colleagues who relieve pressure from subdural hematomas from GLFs can attest to that. So in general, the first fact sheet I wanted to just leave with you is odontoid fractures at this point in time now are the most common cervical spine fracture in patients above 65. It's a very vulnerable structure, and it's growing actually faster than the geriatric population, which is already disproportionately growing. And the actual cost has been calculated. It's $1.5 billion in the US per year for odontoid fractures. So this is the general workup. And again, when you see elderly patients, you frequently see this conundrum of kyphosis in the subaxial spine and cervical thoracic junction. All of us know that gibbous that elderly people have, and they compensate for this with a hyperlordotic craniocervical junction. And you see a lot of bone and soft tissues forming. We still want to get lateral x-rays. I do think that open mouth odontoid views are a good workup. And again, we want to get CTs and insist on reformats to better understand what's actually going on there. And again, MRIs are indicated for neurology, ligaments, and soft tissue pannus if we suspect thus based upon our assessment of the soft tissues of a patient, specifically their joints. One problem of odontoid fractures is that we easily miss them if we don't get reformats. This is a classic situation for the older physicians like Cameron and me, where we did not automatically get reformats and we had to really ask for them to not miss these fractures, because if the cut was done in the gantry angle of the fracture, we could totally miss it, and that was a common problem in my era. One factor that is still somewhat unsatisfactory is that despite a couple of publications proclaiming the opposite, it is still very hard for us to pick up ligaments precisely on MRI. Specifically, the transverse atlantal ligament that connects the left to the right lateral mass and traps the odontoid in its groove is very hard to particularly pick up, and it has a significant impact on our treatment choices. Another physiologic factor that, together with the general osteoporosis crisis, we have to face is the osteopenia phenomenon of the odontoid. And these are slides from Michael Hagenus's famous paper, from 1990, where he basically showed that physiologically we lose over half of our bone mass in the odontoid at its worst place, and that is in the middle of the odontoid waist. So this is a bone structure which actually has a pretty good blood supply for a long time until it then shuts down, as Joe has shown with his wonderful paper. And this leads to a loss of bone mass right where we need it most, in this vulnerable point. Another simple physiologic factor comes from Michael Meyer from Munich, who showed that the actual bone surface is really small. It's about a square centimeter. And if this bone surface of 1 square centimeter at the waist of the odontoid doesn't match up nearly perfectly, not only do we lose our rotational capacity of the atlas to odontoid, or atlas to axis, which is about 30, 40 degrees in each direction, it actually also won't have a chance to really heal. So the odontoid is a pivot point for the upper cervical spine, providing half of the rotation. Now there's another phenomenon that happens as we age, which is really poorly understood and usually not referenced by our radiologists. That is that there is a atlanto-odontoidal arthropathy. So if you look carefully at a lot of CT scans, we see that this area where we have the ala ligaments fills in with bone. And this kind of stiffens up the motility of the odontoid as it tries to pivot around its groove in the atlas. What also happens in these patients is that the atlantoaxial joints actually remain pretty unperturbed. So we have a situation where the atlas stiffens up against the odontoid itself, but the base of the odontoid in the axis remains mobile. And this is an obvious setup for if a simple fracture happens, this will break. And so this is the break point, the failure point of our entire cervical spine is in this little pinky-shaped, I can't help myself, but say pinky here, fracture. So again, this is the brief summary sheet of this. These are very common fractures now. The most common C-spine fracture in patients above 70. Most of these fractures occur around the waist of the odontoid, way more females than males, and low energy falls are the most common prevalence. And there is a over 40% mortality described in some papers. So it's a very problematic fracture to have, and complications of any form of treatment can approximate 50%. So those are coming out some of the sobering facts and missed injuries. So I mentioned classifications a couple of times, and one of the most best known classifications in all of our musculoskeletal medicine is the odontoid fracture classification of Anderson D'Alonzo. This is not Paul Anderson, my faculty mentor when I came here to Seattle. And this is basically identifying that fractures in the waist are type 2 injuries, and any fracture that goes into the bottom area is a type 3 injury. Now, sadly, something that seems so intuitively clear, yet again is met with indecision in medicine. Specifically, our radiology colleagues frequently misclassify injuries that go a little bit into the mass of the axis as type 3 injuries. And again, we need to make sure that everyone is on the same page. It's truly a fracture into the base of the atlas, which is into the base of the axis, which is a type 3 injury. So anything which has a preponderance of the fracture in the waist is a type 2. John Grauer, a former fellow of Alex Vaccaro from Philly, now at Yale, identified that there are some subvariants which are important to point out. So the angulation does matter. And so this is something I would just recommend writing or spelling out. He put numbers to it, but that's too confusing. So type 2 injuries are the problem, and anything where the majority of the fracture is around the waist is and remains the problem fracture. Now, non-operative treatment. The basic two options are some form of a collar or a halo, which you see, that's not a patient of mine, shown here on the right side. And again, for any displaced fracture, this is a very big question of if this is actually an ideal treatment. I want to say something about the halo. This is something that fulfills a lot of us with fear. When I came here 3 years ago, I actually gave a lecture on halos. Rod asked me to talk about halos at the time. And as it so happens, I had a halo patient here in house, and I actually rolled the patient with her permission into the audience, and she actually did well. The halo was something that was actually not developed for fracture care. It was developed for polio treatment. And this is the inventor of the halo, Vern Nickel, who I actually had the privilege of meeting personally. And this is a polio patient where he did fine adjustments. So this was not really done for fracture care. The problem of this is nowadays when we have trauma patients, Again, this is something that is not really amenable towards trauma care because it does occlude the chest. But of all of our non-operative options, this offers by far the highest immobilization potential for the upper cervical spine, defined as C4 and upwards. This is actually an important slide for me. I got this from a patient of mine. This is the father of a patient of mine who had an odontoid fracture. This is the mother of a patient of mine who had an odontoid fracture. And they actually got treated with the two main treatment options of odontoid fractures up to the 1970s. She had a so-called Minerva cast, and this is a true old Vern nickel type halo done for polio treatment. And she had an odontoid fracture, and she said, I'm not getting either of those, I'm getting surgery. So that was her story. So immobilization, if you want to do that, if you really need it, is best done with a halo. Now, what's the problem? There are numerous papers that have shown that non-operative care with any form of non-operative method, even halos, has a significant non-union rate. And this is kind of a brief survey of the literature up through the 2000s. And again, the numbers are typical medicine all over the map, from 10% non-union rates to about 3/4 of patients. So the displacement and angulations, numbers of characteristics would come up. But basically, a lot of doctors felt that there were many complication rates due to halos, and halos became really kind of bad actors. The famous Alex Vaccaro from Philadelphia always would argue against me on public stages by going like, Chapman wants you to be in a halo, and this is his patient who wants to get out of jail. So this was his classic line. He got a lot of laughs for that, more than I did. But these are the kind of immobilization characteristics. And again, there's no question that if you put on a halo, that is not a benign treatment. This is a patient from Harborview where somebody did not understand that this patient had a temporal bone fracture, and after application of a halo, this became a depressed open skull fracture. So that's not a good idea. Proper application technique and awareness of the skull morphology. And in a previous paper of ours, we showed that the critical thing for success of a halo is not that, this is important, but the torso fit. So if you have a patient you want to treat with a halo, the vest torso fit is critical. If you have somebody who's voluminous, I think I'm on the borderline, that is not a good idea. But Cameron would be an ideal patient for a halo. If you wanted to do that, we'd be happy to help you with that. So many complication papers have been written about halos, and the most feared one is that the pin actually penetrates the skull and gets a deep infection. But you can basically see a summary of papers. And again, the infection is the most prevalent one. It's a pin tract infection, usually with staph, that migrates inwards and can cause significant problems in some patients. And the pin interface is the problem. Meticulous pin care is necessary. So let me show you something. We actually did a very comprehensive reassessment to provide some science to this. We had 292 patients at Harborview. A lot of them were odontoid fractures, but not the majority. And again, we did identify some things that we found were very interesting. A halo can work very nicely. This is a displaced odontoid fracture, and this is a patient with ankylosing spondylitis who healed with a halo. We had a very vigorous pin tract care protocol. We actually documented a pin tract infection rate of 5%, which is way lower than most people in the literature. And as we looked at a number of indications, you basically see that they're mainly centered around upper cervical spine injuries with odontoid fractures here in the middle. We also looked at age being a factor, and we found that age was not a major failure rate, but we found something really interesting. The vast majority of halo failures occurred within the first 2 weeks. So in this conundrum of if you decide to have the most effective non-operative treatment that we're aware of, biomechanically speaking, and if you're just wanting to really try it, you can make up your mind and switch gears to surgery within the first 1 to 2 weeks. That's the take-home message. So you're not binding yourself and seeing failures late after a patient has already invested 3 months of treatment, which was the main treatment time that we had used. So basically, the first failure rates were in the early stages, and the vast majority of patients were able to complete their treatment to 3 months without treatment-changing interventions. So what can we conclude from halos from our experience at Harborview? The pin tract problems, if you have a vigorous education and management protocol, are totally manageable. About a third of halos do fail, and they usually happen early on. And it does remain a legitimate option for select patients. For instance, non-compliant patients, are very well treated with halos because they actually have to come back and you can keep them in a controlled environment. That was a big learning insight. So patients who remove their collars, which we actually had a lot, we actually wrapped some patients with fiberglass, and that's not a good idea to keep them in collars. Now, let me just give you a different perspective. So there was a recent meta-analysis from the UK. I don't know any of these authors, but they collected, and that includes Harborview patients, 714 patients. The majority of those were type 2 odontoid fractures. And basically, in this large systemic review, which is always something fraught with some imprecision and suspicion, they actually found no difference in terms of collars versus halos for type 2 injuries. They did find a higher failure rate of collars relative to halos for type 3 injuries. They did acknowledge, again, this weird conundrum that you could stiffen up a lot of these fractures without getting a real bony healing. So don't read this, but this is kind of a summary of a lot of their papers, and there are 2 of ours in there with Charlie Kuntz. And they did identify far more complications with halos, and yet again, pin tract infections and medical complications due to pulmonary problems were the leading problems with halos, making them not so desirable. So in essence, the authors concluded that a halo in their big picture review of the literature was not really necessary and may have a role for type 3 odontoid fractures. My proposal is a very simple one. If we have a non or minimally displaced odontoid fracture, we can put them into a Miami J type collar. This is, by the way, and there's no product placement here. This is the best, biomechanically speaking, collar, rigid collar that we have. So this is an ideal patient for a non-operative treatment of the collar. And then we sit them up. We get a recumbent lateral, we get an upright lateral. And if this happens, voila, we know that this patient will need surgery, period. And that's the simplest way of assessing stability. So recumbent, an upright lateral, and a rigid collar. You can do the same thing with a halo. And again, you have your decision made for you radiographically right there. So now, going back to Bob Hart's paper, do we actually really need to have a union of an odontoid fracture to be happy? Of course, instinctively and intuitively, we want to have that. And he showed in 5 patients whose mental status only he can attest to, and he's not here to personally be questioned by myself and publicly state that. But these were pretty out of it patients who couldn't verbalize what's going on. There's one other paper, again from the UK, and again in the UK, no disrespect, but I've worked in the NHS for 4 months, and I was always amazed at the stoicism of British patients and kind of the stiff upper lip approach of the patients there. It was carry on, it's just a little non-union, don't worry about it. So they had 9 patients, they also found no neurologic deficit. So catastrophic neurologic deterioration does not seem to be a common occurrence. So the do nothing proposal does have a little bit of support. Now this is a patient of mine who came into my clinic with a clear odontoid non-union. This is a hypertrophic non-union with significant cord compression. His story was pretty interesting. It's a Viet Cong soldier, a former Viet Cong soldier who was in his early 70s. And he actually spoke English very well. Tanya knows of his story actually because she was in the UW system at the time. He's severely myelopathic. And he'd been treated non-operatively by an East German. He swears to it. I asked him multiple times, and he speaks very good English. He came to us, the losing nation. I always made point of that to him. So he came to us. He was treated for 3 months in traction in an underground hospital whilst Rolling Thunder went over him. And he had an East German surgeon basically treat him and supervise his treatment underground for 3 months. And then he was put into Halo for another 3 months, and he never really healed. So he had a myelopathy with this very significant hypertrophic arthropathy. We actually did, good morning, Syed. There's plenty of chairs right in front of me, and I promise I'm not going to torture you. So we actually did operate on him. So neurologic compromises do happen, but it is probably not a very common phenomenon. So there was a paper that our friends from Philadelphia wrote, who've been very active in this, and they identified a pretty large number of patients who had these chronic non-unions. And against the largest known series so far, interestingly, almost none of those patients had a real trauma history. This was incidentally picked up at some point in time, and whether or not these patients had a real injury mechanism was not known at that point in time. They're elderly patients, and they only found about 20, so 1 in 5 patients roughly having neurologic compromise from their never healed odontoid fractures. So that's, again, the largest number, and probably a better number to keep in mind, 1 in 5 patients will develop some neurology. Now, most of these patients, Chris Kepler will attest to that, were again not cognitively totally with it. We did a larger prospective study, and again, we looked at 58 patients who had nonunions, basically, that were treated non-operatively, and again, we did identify a significant mortality in non-operatively treated patients with acute fractures, and we did identify 1/3 of patients, of these non-operatively treated patients, who got symptomatic non-unions. And these were very carefully treated according to a protocol and prospectively followed up. Switching gears to surgery. So I always come from the old world, and one of my mentors was the man on the top right, Max Avey, who is not known to be subtle in his opinions. And again, his opinion was, and I'll give you the index finger here, not the middle finger. That was what he always would teach us with. This is a German, Kevin's a German teaching principle here. So if you see me doing that, that's Max Avey's fault. He would always tell us, this is what you do. And that's what we did. So the odontoid screw was one of the most elegant revolutions imaginable. And again, AO, the Swiss organization, that's global now with over 30,000 surgeon members, was in part founded by him. And again, the odontoid screw was going to be a solution for everything. And this was taught. And again, it's a very major breakthrough. We'll talk about what that means in a second. What came out of multiple papers was this. There are a couple of things, and I call them the FDA questions when you look at an odontoid. Fracture level, comminution, distraction, direction of displacement, and for A, angulation of fracture and fragments that matters. So this is what you want to see and look at when you see these fractures. What has come out over time is that bad prognostic factors for a non-union are distractions of more than 3 to 5 millimeters, angulation of more than 5 degrees. This is a particularly bad variant where the atlas tilts laterally, and a combination of atlas fractures or TAL disruptions, which is why MRIs can be so important in combination with any form of an odontoid fracture. Any patient who has a spine deformity, like this ankylosing spondylitis patient, is at a supreme risk of a non-union and usually very disabled if an odontoid fracture is not fixed. So this is this patient's odontoid, and we desperately were trying to get it into the same ballpark. And we actually were shifting around. This is in a halo, trying to chase this fracture. Obviously, as I told you earlier, if you have a body habitus like this, and this is not a patient from our review, I want to point that out. I once got accused of having shown this side on a Harvey patient. This is not a Seattle patient. This is a Parkland patient, if you look carefully, from Dallas, Texas. If you don't have a good torso fit, non-operative treatment does not really work. So we did a paper on looking at how trends changed over time using a larger captive population in the state of Pennsylvania. And we found that over time, surgery clearly, since the 1990s, gained significant prevalence over non-operative treatment. So that was a shift, a paradigm shift in treatment that, again, is reflected in my own experience. We had simple cables and wires as our only treatment option in the 1990s, and we had to use halos. And after rigid fixation, like Dr. Avey's famous screw fixation, came to more popularity, suddenly surgery became far more prevalent. Now, what kind of surgery is another question. We have a number of surgical options. The classic cable fixation in the back is, again, something that all of us, Ryder's nodding his head, were trained in. And again, our younger generation doesn't know that anymore, right? So Galley and Brooks means little to nothing to you. But this was gold standard, and mind you, in the 1990s, this is one of those old man tales. This was the height of internal fixation, and we're so worried about this, and this was biomechanically not rigid. A true breakthrough was when Fritz Magel from Switzerland developed an elegant technique to put screws between the base of the inferior articular process into the atlas arch, and also sometimes into the vertebral arteries, leading to emergent consults to the colleagues of Akshal and Cameron. And a breakthrough came from Goel from India and Harms from Germany, who developed a segmental form of fixation. And that's, again, something that our fellows, when this technique started becoming available in the early 2000s, rushed to. Believe it or not, in Germany, they have surgeons who open up the pharynx and put plates on the front of the atlas and the axis. And we may actually get one of those doctors here in our trauma course next May, Frank Canziora. They have very elegant plates, and I can't even begin to imagine doing that because Again, right? Can you imagine that, Rod? It sounds crazy, infection rate and everything. And then we have Professor Aby's famous odontoid screws as maybe the most exciting anatomic and non-fusion-based treatment. And this, again, proposed to maintain motion, be very atraumatic. And truly, speaking as a surgeon, Zaid, have you ever done odontoid screws? Am I speaking right? I mean, this is one of the most elegant procedures. It's technically beautiful. 2 C-arm setup, minimal exposure. You have to have a nice trajectory, usually at C5-6. You have to dig into the C2-3 disc space and then put this 1 screw in. You don't need 2 screws, and you have a perfect result. The problem is basically the thought that we could maintain motion of the atlantoaxial joint is not true. Benny Jeannolet from Switzerland showed in an elegant CT rotation study that basically you don't maintain motion there. So the motion preservation myth was busted, but it remains a very elegant surgery. Here's a 2-screw patient, and very satisfying if it works. The problem is that when we did a mini-meta-analysis of the main publications of this, there are many, many complications of these screw fixations. And again, the complication rate was about 14% on average, but some larger papers said about 33%. And the problem was, again, the main issues were 2 things. Number 1, bad patient selection. Number 2, bad technique. And here's one representative case for both. This patient had a screw placed, and the surgeon drilled the starting spot not into the C2-3 disc space, but a little bit too anterior, and the screw was skiving along the anterior cortex and then simply broke out, leading to this unstable non-union. And now you have a real problem. You have an unstable piece of hardware that is right behind the esophagus, shifting back and forth in an elderly patient. So this is a classic problem that we've seen more and more, and we had a couple of those patients here also. And this obviously required a stable fusion afterwards, once you have an established non-union like this. So these screw fixations had a number of contraindications that emerged over time, and that led to a more restrictive application to the point where basically we don't like recommending it for elderly patients anymore. And the other factor was, again, in Michael Meyer's elegant study, he showed that between 1 and 2 screws, there are a lot of non-unions if you use simply 1 screw, and if you did not have an absolutely anatomic, like he showed here, reduction. So truly an odontoid screw is something where you have to have a perfect reduction and a perfect patient with perfect technique. And again, the superimposition of bone is hard to achieve, and only if you have this perfect superimposition can you then hope that you get a union. And this is a case of his out of his paper where he showed that he got a non-union. And those who know Michael Meyer from Munich, I'm very partial towards him, obviously, because he's a friend of mine. But this is a very exacting surgeon. It's very frustrating for him to have to report that, especially with single screw fixation in his hands, if he did not have everything perfect, they would not heal, and these screws would actually block bony union. Now, we did a couple of other studies. We actually looked at comparisons of front to back surgeries. And again, there was clearly a way lower blood loss if we went anteriorly for odontoid fractures. But the problem is, again, the odontoid is literally right behind the pharynx. By the way, a reduction technique that we frequently would use is in an asleep patient. We put our thumb into the patient's mouth and push the odontoid peg back. Did you do that, Axel? Have you taught that? So that's a classic trick. And again, the problem is any hardware prominence there, anything that is out of place, will lead to a very high degree of dysphagia and also a denervation of the superior laryngeal plexus. And Professor Tubbs, if you would be speaking here or present here, would debate me on that. He thinks that there's a segmental innervation. Right, Joe? You're going to explore that right now with a grant proposal. This was one of the biggest problems we found in a prospective study on anterior versus posterior. When we did an anterior only versus posterior surgery, we found that when there were airway problems, they were almost always in anterior procedures. And swallowing and vocal cord problems almost did not happen in posterior procedures, but in anterior procedures, about a quarter of the patients had significant vocal cord or swallowing problems. So this is an insight, especially as an elderly patients, we already have swallowing problems because we have that denervation of the superior laryngeal plexus. So there's a denucleation taking place. If we then add surgical trauma to that and a hematoma maybe, those patients will develop swallowing problems. Which led us to conclude that posterior fixation is way better. And again, this is where Goel and Harms in 2001 later identified the miracle of putting screws into the atlas right around the C2 root and sparing, hopefully, the vertebral artery with good surgical planning and execution, and with the knowledge of having an excellent vascular team right available if need be. So this is the art and the beauty of this, and it was interesting for me to see. I was a fan of doing the transarticular screws, but our fellows at Harborview always got to choose what we did, and they chose hands down doing the segmental fixations. It's just easier, you can do a reduction in the field, and it worked quite nicely. So the post-instrumentation, you have to do your planning, you have to know exactly what's going on. You can look at the videos on SSF. We, on our trauma courses, thanks to Rod's support, have a great number of very cool lectures of some of the true leaders like Rick Sasso, who shows how to put devices into C1, C2 with high precision. And you want to be aware of the vascular anatomy, and you don't want to do this. You don't want to fire screws into a patient who has a vertebral artery injury and then injure the healthy side. We did a study on changes in surgical habits over time, and again, looking at larger sentinel studies that we collected from 3 larger centers around the country, including Harborview. We looked at the fate of odontoid screws, which is in this field number 1, and you can see that it kind of made a little surge in the mid-90s, and then it really petered out. In the late 2000s, it basically became very unrecognizable. The Brooks fusions, so cable-type fusions, and field number 4, which is this on top. And again, this was the prevalent form of fixation, and then really almost went into non-existence in the mid-2000s. The fact that our fellows shook their heads, right, Josh? Didn't do it anymore, tells a tale. The Mogel transarticular screws were in field number 3. Let's listen again. This basically is petering out also. And have you done one, Amir? Have you done Mogel screws? No. And the Harms fixation is basically, boom, just exploded. So this really shows dynamically how surgeons voted in terms of what their preferred technique is. Charles, did you do a lot of odontoid screws?
I did, but I stopped in older patients because
Yeah, we showed swallowing slides before. Very, very rarely are occipital fusions necessary in these patients. So Harms is clearly the way, the Harms-Guel technique. One other thing that we saw was what happens in terms of age and prevalence. And again, we were just astounded by how many patients are in their older age category. You can see these are all 70s and 80s patients. Very few nowadays are younger. And again, the ultimate outcome was that death, the older you get, gets more prevalent. Home discharges are very rarely possible. Most of these patients have to go to a nursing unit afterwards, especially as you get older. So that's a disposition insight that we thought was very important. Let me just show you the mainstay of this lecture, which is we actually did a prospective long-term follow-up study on 322 patients with odontoid fractures. It was a multi-center study. We're very proud to have done this. And we basically followed these patients for 2 years prospectively, like an FDA study. And we identified a couple of shocking numbers. And this is, again, around the country with major centers involved, like UVA. Tanya probably saw some of those patients. Non-operative patients had a 44% 2-year mortality. Again, these are elderly patients, as you saw on that slide. Surgical patients did have a mortality of about 51%. This is an AO study, which is a nonprofit organization. And again, we wanted to see what the short-term follow-ups were. We allowed any form of non-operative treatment and any form of surgical treatment, including odontoid screws. And again, this is unreadable, but I just want to point out that the demographics were remarkably similar. This was not randomized. This is a prospective observational trial of patient-surgeon preference. Of course, there's a risk of bias, and I want to make this very clear, and we always point that out. We really tried to make sure that we had a very clear understanding of the demographics, and you can criticize that, for instance, in the non-operative group, there was a higher group of patients with independent living arrangements than the surgically treated ones. So there is a possible bias that I really want to make sure exists. But if you go on to, for instance, fall mechanisms, they're very similar in both groups. If at all, they disfavored the surgical group. These are the comorbidities, and again, you can see that literally every patient had some form of a serious comorbidity reflected in something called Charlson comorbidity score. So the survival rates, and these are the raw numbers of surgical treatments around the country, of the test centers involved, and again, these are some more demographics in terms of disposition. Hospital length of stay was actually shorter, half the length of stay in non-operative patients compared to surgical ones. And feeding tube placement was more prevalently found in surgical patients, reflective largely of the odontoid screws. There was a close tie of odontoid screws and feeding tubes, which is not a good disposition. The discharge disposition, again, there was a clear prevalence of non-operative patients dying during the hospital stay more than the surgically treated group. These are the basic numbers, and I'm going to show you graphs in a second. That's more important, but basically we found a very surprising trend towards having a better survival chance with surgical treatment compared to non-operative treatment, although the demographics seem to favor the non-operative group. There's something called the Cox regression analysis. Branko Kopiar, who was here recently, did the statistics for us from the UW epidemiology group. We found again that the comorbidity was very similar and statistically different. And basically we saw that patients in 30 days actually had a better chance of survival, that's the blue line on top, if they were operated on, compared to non-operative patients, which was a surprise. And as we followed this up over time and then did a mathematical extrapolation to 2,000 days past surgery, we found again a clear trend change. It was statistically significant of better survival of surgically treated patients to non-operative patients. There are obviously many questions about bias. They're going to want to address these right up front. So what really mattered and what was different versus not was age was a significant risk factor for adverse outcomes. Comorbidities, again, this is an odds ratio, so 3.6. If the more comorbidities you have, the more likely you're not going to make it. And again, male gender was unfavorable, and any feeding tube placement was a major problem. So this led us actually to conclude in our paper that if you are worried about nutrition of a patient, probably a PEG tube is better than a nasogastric feeding tube, irregardless of whether you did anterior posterior surgery or non-operative treatment. So feeding, alimentation should be through the stomach directly. Feeding tube placement between surgical and non-surgical treatment patients was a major risk factor. So one take-home message there, regardless of what your treatment choice is, if you have an acute odontoid fracture you want to treat it, don't put anything down their nose, put it into the stomach directly. Now, another outcome study that we did was a surprising insight for us, and that's the Vulture neck. And I'm sure you recognize what I'm trying to say with this. This is very prototypical for many of our elderly patients who walk with a cervicothoracic kyphosis and hypercompensate with a craniocervical junction. So we actually studied this in terms of quality of life. We actually won a Best Paper Award from that. And we found that basically patients with non-operative treatment had a worse neck disability index. It was statistically significant but not massive in terms of NDIs. The physical performance score was same. The mental health was better in patients who were treated surgically than non-surgically. So we went on to look at why this might be. And one of our former fellows, Max Reinhold from Leipzig in Germany, developed this spinal column theory, which he actually pirated from another fellow, the late Charlie Kuntz, from the Mayfield Clinic. He basically identified that the foramen magnum should be superimposed over the spinal canal at C71. And he created this beautiful column theory that he mathematically calculated. You can read that up if you're really wanting to go to sleep in the European Spine Journal in 2012. What we had seen was that over time, regardless of surgery or non-surgery, patients who are in a collar and who are elderly would sag forwards, like you can see here in their necks. So they would actually accentuate this Vulture position. And this was, again, the dynamic measurements that he performed over time, regardless of treatment, but especially in non-operative patients with a collar. This was a common phenomenon, and this was actually irreversible. So even after PT was done, what we basically identified over time was that this was closely tied to unhappy patients. So this front sag is something we really need to avoid. And how do we avoid this? We probably really have to think about surgery in that regard. Because if you do surgery and you're comfortable letting the patients out of their collar and activate and encourage their posture, you can actually avoid this Vulture position. Finally, in the final paper I'm going to come and quote here, as we're 5 minutes from close, cost effectiveness. Many of us are nowadays challenged to actually look at the dollars and cents of what we're actually doing, and this is something that is a deep anathema for older practitioners like myself, but this is what Kevin Clower and the MBA people ask us to also look at, and that's right. So we have a number of qualifiers for that. Pure dollars is one thing, and then so-called QALYs, quality of life-adjusted years, or ICERs, incremental cost-effectiveness ratios, and I'll show you those slides. This is Daniel Barlow, who did this study together with Anna Tostesen from Sweden, and she's an eminent specialist in this. And they basically identified without a doubt that surgery is more expensive than non-surgical care. You saw the length of hospital stay as probably the major component of this. And if you had complications again, surgery would be more expensive than non-operative treatment. The cost analysis also identified, so these are the total costs. Sorry, animations in here which are useless. So this is the main thing. Interestingly, when you then translate that into quality-adjusted life years, we identified that surgical treatment was actually more cost-effective. And why is that? Because the patients basically would have a better quality of life. And if you actually put that into dollars to make this difference of a better quality of life, the healthcare system would have to invest $12,000. So in other words, if you're willing to invest $12,000 in a captive population, like the Kaiser population, if it was worth the health plan to invest $12,000, you could give the patient a better quality of life. That's the methodological equation in this. For non-operative patients, as you get older, so in the 75 plus range, the price tag goes up. You have to invest $40,000. So for a younger group, 65 plus, $12,000 with surgery gives you a high chance of a better quality of life. If you're willing, as a healthcare system, to put in $40,000, that's better. That's $40,000 investment in healthcare. And the over 85 patient population, interestingly, the numbers flip around, and there again, it's a toss-up as to what you determine to do. The quality of life becomes far more problematic in terms of trying to differentiate it. Now, this is the case I showed you earlier. Remember that? Ryder had said surgery. What surgery would you choose if this patient, now what you've heard about, odontoid screws?
I still love the odontoid screws so much. I know it's not right, but I would want to do it.
Okay, Axel, do you like your father?
I would do a C1
Posterior, segmental. Tim, what would you do?
Sounds like the harms.
Harms? Rod?
I'd probably get an MRI.
Why? Spend more
Just
money?
because C4, 5 looks kind of tight.
Okay, that's good.
But yeah, I'd probably posterior. Something
Posterior.
posterior.
Charlie?
I want to do posterior, but it's a pretty weird inclination there. I probably want to that floor over there.
Yeah, posterior, but we need transplant there or something. These older people with the heart or
Plan carefully, be flexible in your. Yeah. So we did a posterior fusion on him. He actually did very well. He survived his 1 year follow-up. And again, the segmental fixation was very nice. This is one of the earlier patients. Now, obviously, studies have been very incomplete, and I spent a lot of time filtering through many studies. There's still no prospective randomized trial. We may never see that. Clearly, a couple of things have become very apparent. In patients who have breathing problems, probably a percutaneous trach might be a problem or might be a benefit, probably the latter. PEG tubes are clearly better than nasogastric tubes. We still don't and can't predict outcomes very well, but basically neurocognitive, and this is a dementia picture that I chose intentionally, neurocognitively intact patients probably benefit from surgery if they're unstable. So what really seems to matter as I looked at the data sets over and over again is how neurocognitive intact patients are. Now this is a case that Rod gave me when I came here, so it's my 3-year anniversary here now, a 98-year-old patient who was bitterly unhappy. And he was in this forward flex position despite a neck collar, his anterior slipped off. I showed you data that shows if you're above 85, there's a big question mark in terms of cost effectiveness. I'm going to repeat my previous question. Let's start with Amir this time. 98-year-old patient. He's on blood thinners. Other than that, he's good. He came from Alaska. And Rod immediately said, like, hey, you wrote about this. Why don't you take care of this patient? And again, this is his neck position. He's very unhappy. He's 3 weeks out. I mean, that's a nice out question. That was exactly what I said. You wrote in my chart. But you're it now. Rod passed the baton to you. Thumbs up, pinky up.
If he's that unhappy, have to be pretty extensive. Possible to correct that. Not a surgery from a perspective.
What do you think, Dave?
Yeah, I would just have to say, sorry, no surgery.
I'm going to poll the audience now. Who is in favor of surgery on a 98-year-old patient who's on blood thinners? Show of hands.
Question mark. How is this guy for this?
He is neurocognitively amazingly with it. He's an Alaskan, and he had a healthy mixture of salmon and alcohol diet throughout his life. But his liver is somewhere 1 hand width under the rib cage. He does not have a psyches. Okay, so show of hands one more time. Who's in favor of surgery? And who's in favor of palliative medicine? Okay, it's an even split. After a lot of weighing, we gave him the thumbs up sign. We did surgery, and the thumbs up sign was really cool because I don't have a picture of him, but in the recovery room, I walked in and he was thumbs up, his head was straight, and he was thrilled. He wore no collar, and he gave me the thumbs up sign and said, "Thanks, doctor." That's a true story. He actually survived. We don't have a follow-up beyond 3 months, I must admit. So, final take-home points: odontoid fractures, most common C-spine fracture. Injuries are associated with a high mortality rate, somewhere between 10 and 25%. Surgery or non-surgery, there's not a simple answer, as you saw. It's a very emotional and intellectually difficult discussion. Surgery does improve in neurocognitive intact patients' survival and quality of life, but there are some patients who tolerate stable nonunions well. Odontoid screw fixation is probably not desirable or not the top option for elderly patients. And for non-operative treatment type 2 odontoid fractures, Hale is not needed. I showed you my simple up and down paradigm with a rigid collar. Non-operative treatment is not benign. And that's all I have to say. And this is 3 years ago when this nice lady, Kristen Muscurian, welcomed me here. So thanks for having me.